Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can thrive, be profitable, and successful for years to come. This week on the Edge Podcast, I welcome back Healthcare Attorney and fellow NSCHBC member Amanda Waesch. Amanda operates a national healthcare legal practice and is licensed in both Ohio and Florida. Also, we welcome returning podcast guest, NSCHBC member David Zetter of Zetter Healthcare. David brings in over 30 years of operational and healthcare experience, along with expertise in all areas of practice, facility management, startups, buy-ins, and provider compensation, and more. I'm excited about our topic today. We're going to dive into the ASC, or Ambulatory Surgery Center, and also mention the Office-Based Lab, or OBL startups, and what the market is telling us now when it comes to giving patients options when having their procedures or surgeries and where to have them. As we all know, hospital costs have risen and continue to do so. So what are the pros and cons and options for physicians and practices when considering opening a potential ASC or office-based lab? So I'm going to start with some of the things I've been really researching this topic, and I want to start with you, David, and welcome actually to the podcast this week.
Thank you. Glad to be here.
Oh, I'm so happy to have both of you back. I really appreciate you both being here and taking the time. What are the most, important trends you're seeing in the ASC or OBL field today? And in your professional opinion, and I know this is going to be a kind of a loaded question, is it the right time for a physician to consider opening an ASC?
Well, from my perspective and what my clients are doing, I've got a lot more opening up OBLs than ASCs at this point, solely because the payers are looking for ways to lower healthcare costs, and an OBL is no different than providing services in the office so you don't have facility fees. You do have OBLs that could potentially have a procedure room accredited or certified, and they can possibly charge facility fees, but the intent here is to lower healthcare costs and to be as effective and efficient as possible. So I've got an awful lot of providers that are starting those up because they're looked more favorably upon by the payers, and they're more apt to obtain contracts with payers, whereas a lot of surgery centers, in my experience, tend to like to be out of network. And with the passing of the No Surprises Act, it just makes it much more difficult to be operating that type of facility and to be able to collect money and convince patients to pay for those services.
Well, and you brought up a really good point, and Amanda, I think I'll throw it to you on this one. So ASCs, obviously, which have stronger payer contracts and management, will retain and attract, excellent surgeons and prosper. But when it comes to the office-based lab or even the ASC space, I've noticed that many networks and panels are now closed to new providers. Is this happening in the ASC space as well, do you know?
Yeah, Terry, that's a great question. I'm opening a number of ASCs across the country, and so far we have not seen where panels have been closed. But I will throw a caveat in there. The ASC projects that I'm working on, most of those are going to be surgeon-led, specific specialties like orthopedics or urology, bariatrics, and they are working closely with the payers to do bundles or value-based arrangements rather than the traditional fee-for-service. And so from the early outset, they're of the mindset that they're going to enter into these value-based or bundled payment arrangements. And it really provides an alternative provider than the traditional hospital setting. The other thing that we're noticing in some of the markets that we're in is that the hospitals have been inundated with COVID. They're down on staffing. They are way behind in these elective surgeries. And so the ASC setting is very preferable for the patients and the payers, and the surgeons simply need to get their cases done. And so we've seen, for the most part, the payers kind of welcoming these alternative providers, with open arms, and then offering them, some, non-traditional payer contracts.
So I've noticed something interesting, and you brought it up as well. And David, I'll have you chime in on this. I've noticed that I'm seeing two different kinds of ASCs, if we're going to start in that space. That there's either the Ambulatory Surgery Center that is all things to everyone, or there's the ones that are specific, small, niche dominant, like an orthopedic. And it seems to me that the ones that are really focused on one specialty seem to be a little bit more manageable. Is that a fair statement, or is it, or is it more that some of the ones that are trying to be everything are trying to basically take the place of a hospital? What is your thought on that?
Well, from my perspective, surgery centers that have a lot of specialties in there, you may have an awful lot of owners that, get involved in that surgery center. They want to perform their own services there. That's understandable. If you have specific proceduralists that are performing those services and they have ownership in there, that's one thing. On the other side of things, you could have an ASC where they go out and seek other providers to perform services in there to generate more income, generate more facility fees. When you start getting into, a plethora of specialties, then it's sometimes harder to run an effective, cost-efficient, and properly run surgery center when you have so many different types of specialties and procedures being performed. So in my experience, I've seen payers that have been less receptive to those huge multi-specialty surgery centers versus those surgery centers that only allow procedures by the owners that have ownership in that surgery center, because normally we're communicating all the ownership disclosures, and that's required when you're doing surgery centers, especially if you're getting accredited or certified. And they want to make sure that the surgery center is going to do what it can to be a good partner in the healthcare system. Now, I know that may seem, somewhat ironic, asking to be a good partner when you're dealing with insurance companies, but that is what they're looking for. They're looking for providers that are going to help lower the cost of healthcare, provide patient access, provide better patient satisfaction, have better outcomes, and provide better quality of care. So that's what all payers are looking for right now. And you need to find a way, in my opinion, to communicate that to a payer when you're trying to contract with them to ensure that you're going to be allowed to participate.
Right. Now, there's something that I don't know if this is a legal question, Amanda, but this is a question that's come up in my mind. And actually, I've seen a couple people post this on a different, social media platforms, and nobody seems to know the answer. So in March, the MedPAC, the Medicare Payment Advisory Commission, came out and said that the total number of ASCs jumped 2% between 2019 and 20. And I would assume it's probably higher now, because if the pandemic has taught us anything, is yet many procedures and surgeries can be shifted from the hospital to an ASC. But my question is, there's been a change in the inpatient only list. And so Medicare and CMS and HHS, they changed that with the new administration coming in and kind of rolled back what the last administration was trying to phase out. Is that just for Medicare? So can private insurances, can they basically say, we'll accept that surgery in an ASC, even if Medicare says no?
Yeah, great question, Terry. We are definitely seeing a shift so we're seeing procedures roll off the inpatient only list, and we're seeing that particularly with orthopedics, right? And so these are procedures that are now able to be performed in a surgery center setting. But the commercial payers were way ahead of Medicare. And so before they rolled off the Medicare inpatient only list, the commercial payers were saying, yeah, you can do this procedure in an ASC setting. So they were ahead of the curve. And so many of our orthopods that were very forward thinking were already negotiating bundled payments with the commercials. And so they were very adept at doing that, with the Medicare patients and working with their local ACOs as, the best provider, or the best, we call it point of service, right? Or the best place of service.
Right.
The most providing the most value, and quality to the patient. Now, that being said, when you talk to the provider, when you talk to the physician, they take place of service selection very seriously. Is this patient a good candidate for the ASC, or should this patient go to the hospital? And they do take that responsibility very seriously. And so if it's done at a hospital, then it's just done on an outpatient basis. But, that patient can stay overnight and be placed in observation. And in some instances, maybe it is an inpatient admission. And maybe, that patient needs to be discharged to, a rehab facility or a SNF. So I think that the physician takes that responsibility of patient choice and selection very seriously. But we do see a shift, and the surgeries are getting very efficient, and, they're going home same day. We have seen also a shift in states where now we allow a 24-hour stay in an ASC. So
Really?
The patient can stay overnight. Yes. And it's actually, in some cases, it's a very nice experience. It's like a hotel or concierge-like experience where the patient does stay overnight and then is discharged the next day. So we've seen a definite shift in various state laws that are allowing that one-night stay or that 24-hour stay in an ASC setting.
Well, isn't typically an ASC for patients that are otherwise healthy, that need their elective surgeries, and hospitals would be those patients that have, you're mentioning the type of patient versus the type of procedure, that have comorbidities and things that have maybe a higher acuity that need that team in the hospital setting versus that can be safely done by this type of patient in an ASC. Isn't that the difference between looking at it as a one-size-fits-all, this procedure can or can't be in an ASC? It's more about the patient, right?
Right. Yeah, it's more about the patient. Should the patient be in an ASC setting, or should the patient be in a hospital setting? Now, if the physician doesn't have privileges at an ASC, so think about a hospital-employed physician, then the only choice may be to take that patient to the hospital and have it done in an outpatient setting. Think, your same-day surgery. So your same-day surgery department is really the same as an ASC. It's just a differently licensed type of provider.
Now, I don't know either one of you that can answer this, but probably both of you. But one of the things that always concerned me is when you have a physician group that owns an ASC, and they only refer to that ASC for the patient. They don't give them an option. Are they allowed to do that? Are they allowed to say, you're going to use my ASC, as long as they just disclose that they're also billing a facility fee? Or do they have to give them an option for an outpatient hospital as well? I guess I'm getting into probably, self-referrals of Stark and all that kind of stuff.
Well, from the standpoint on my knowledge base and what I communicate to my clients is that if they have ownership in any type of facility, whether it's imaging, surgery center, they have to make that known to the patient. That way the patient can make their decision on where they want their procedure or their services performed.
Okay. Does that sound right as far as a legal position, Amanda?
Yes, absolutely. So for purposes of the Stark Law, David threw in imaging. The Stark Law requires physicians to disclose if they have an ownership in an imaging facility or an imaging modality. Now, surgery centers are the services that are provided there are not designated health services, so we're not subject to Stark. But physicians should disclose their ownership in an ASC, and many times there could be a state law that requires the disclosure of that ownership. But I always encourage my physicians, if they have an ownership in a surgery center, they should be proud of it. Use it as a marketing tool. I am responsible for this surgery center. I am proud to be an owner. I'm in charge of everything from A to Z, and I want you as a patient to feel safe here. But David's absolutely right. You should disclose that up front, and you should give your patients a choice. Obviously, that choice is going to be limited to where the physician has privileges, but you should be open and honest with your patients.
Okay. Now that makes a ton of sense. Now, David, I have a question for you. Obviously, starting an ASC, you can't just wish that money for startup costs. I'm seeing anywhere from 14 to 18 million. That was from a Becker's hospital review. Are banks offering this kind of funding, or do physicians need to seek out venture funding companies for capital, or should they start small with the office-based lab, even though I would assume that the office-based lab doesn't have as many procedures that can be done as an ASC? I could be wrong about that.
Well, you're right. Office-based labs usually tend to have a less number of procedures. I mean, there are certain, procedures that you can do in an office, and that's what that office-based lab allows for. From the standpoint on, what procedures you're going to be doing and when they're going to be done and so on, I would just suggest that you really focus on what you want done, what you want your either OBL or ASC to look like, and then make sure that those procedures are being done properly. Make sure that you've reviewed everything, and make sure that every payer is aware of what you're doing to ensure that you're going to get payment, and to make sure that those services can be done in that type of facility. To answer your question on whether a bank actually loans that kind of money, that really requires or depends on a lot of variables. Credit ratings, what the revenue is being generated by the practice, whether the ASC is going to be a separate entity, who the owners are, all kinds of things. Normally a bank's looking at wanting to know some kind of a proforma so they can see what the projections are, help them understand what the business plan is, how those numbers are actually being derived, and whether they can trust those numbers to ensure that the monthly payments on those loans are going to be made. So I think in some cases, yes, there are banks out there that are willing to loan the money, but it's normally going to be a banker that you already have some kind of relationship with, because they're going to know your business. And those bankers that don't know your business, or you don't have a relationship, are probably going to be a little bit more wary, or going to ask for an awful lot more information so that they can understand the risk associated with those loans.
Okay, so that's actually really good information. And before I continue with some of my questions on this, because I just find this topic so fascinating and interesting. I love when the providers can find these revenue streams that also, like Amanda said, help not only with their marketing, but I would think this would help with, surveys on patients and some of those, value-based services, and just patients being really happy with things. But I have a question. Both of you, now, Amanda, you said you've been helping to start up and opening, a lot of these ASCs. And David, I would assume you're involved in this as well, correct?
Yes.
Okay, so, listeners, if you're listening to this, please, if you're even considering opening an ASC or an office-based lab, go to the NSCHBC website, go to Find a Consultant. You can type in David or Amanda's first name, and their information comes up. Now, for me, my role, if you need coding and billing, that's where I would be down the line. So I do not help start these up, but definitely with David and Amanda, this is where you'd want to, kind of look at that if you're considering this, because it sounds like it's something that is a positive thing to tackle or consider, but also it has a lot of moving parts to it, if you will. And I think that just trying to do it on your own would probably not be the best idea. So moving on to a topic that I'm noticing, and this is strange to me. So I know that a lot of you also, both of you probably read the Becker's Health, and that, just so for the listeners, that is a publication that puts out a lot of information in the healthcare industry, trends that are happening. It's a very respected publication. But I'm seeing articles 1 minute where they say, ASCs are awesome. They are, platforms that have lower costs, they're effective, they're in payer markets, they're preparing for migration for models for all kinds of things for the physician. And then the next line they say, well, now due to high cost from equipment to supplies to staffing shortages and everything, we're running into situations where a simple box of 10 surgical dressings can be $1,000 compared to what it used to be at $200. But I'm actually seeing ASCs win in their market in the next few years. I'm not seeing it being a negative, even though I'm seeing a back and forth on, is it too expensive to start, or is it something that you really feel that this is a good idea and an appropriate time to start as we're coming to kind of hopefully the end of the pandemic and we're trying to really shift some things here. Amanda, I'll start with you. What do you think about that?
So Terry, I'd like to piggyback on something that David said previously, and that is to have a good pro forma. So I think that a successful ASC is only as good as its initial pro forma and the physicians who are investing in it. And when I use the term invest, I mean not only investing their money, but also investing their time and their effort to really make the ASC successful. And it's also going to be dependent upon if the physicians have a partner and who that partner is. Sometimes the partner is a hospital or health system. Sometimes it is an ASC management company. Sometimes it's a PE firm. But there are lots of different potential ASC partners out there. It is big business. ASCs can be very profitable, but it is expensive to run an ASC. It's expensive to run any healthcare provider. But they are successful if they're run efficiently and all of the investors are invested in the project. And again, invested means invested all the way around, not just with their money. Also, from the OBL perspective, again, it's going to depend on the pro forma. How much are you willing to invest, or how much can you invest? How much can you, how much are you able to obtain in financing? But what kind of services are you providing? Some of the payers reimburse globally at a higher rate for services provided in an OBL than they do for services provided in an ASC when you look at the professional component and the facility fee. So you have to do that analysis as well to see whether it's better to have an ASC or have an OBL entity. And then in some cases, I see a lot of hybrids. So it's the same building, 2 different entities, and 2 days a week they operate a surgery center, and 3 days a week they operate an OBL. Now, so you could do this hybrid. You want to check your state licensure rules, but that is an option that we see as well. Another trend, and this is something that Becker's may be picking up on, is that a lot of payers are looking very closely at the hospital surgery centers that are in the market, because they're going to be charging hospital outpatient rates. Sometimes, we refer to them as HOPDs. And so their facility fees are going to be way higher than the facility fees under the Ambulatory Surgery Center fee schedule. And so we see some pushing in the marketplace from the payers saying, no, we're not going to pay these exorbitant hospital rates when you're providing the same services as the ASC down the street. And so a lot of hospitals are looking to maybe turn some of their HOPDs into joint ventures with their local physicians that are really going to be ASCs and getting paid under the ASC fee schedule. So there's just a lot of factors and a lot of changes going on right now. And so I'm not surprised that Becker's is kind of issuing a couple of articles that may be conflicting or just new information, because we're just seeing, new things pop up in the marketplace all the time.
Now, what would you recommend, and I'm going to throw this over to you, David. Amanda brought up something earlier regarding the No Surprises Act, and I know we're all kind of deep into that as far as making sure our clients are protected and understand what that means. Like Amanda said, a lot of the ASCs were doing a lot of things out of network, but now would you recommend that they do get on a network, on a panel, just because of the hassle of having to do the good faith estimates and not sure if the negotiation, I would hate to get into, one of the IDRs and try to have to figure out, what we're going to have to do as far as negotiate with a payer down the line. Is it really good business to, if you're going to open this, to get on a panel and make sure that you're, a choice for a patient?
Well, I think so. From the standpoint on practices and surgery centers and so on that are trying to do things out of network, I just think you look into a crystal ball and you look into the future. I think this is going to be a much more difficult thing way down the road to be providing services out of network. I see payers dropping out of network benefits from plans that they used to provide them for. So I even have friends that used to have out of network benefits in their health plan, and now it's gone when they renew it. So payers are getting away from paying out of network. They want to because it costs them more money. And you have a lot more payers that don't have out of network payment processes or policies. There are a few out there that still do. I know United Healthcare does. I believe Aetna does, but you've got an awful lot of payers that don't have out of network benefits. And I think that's going to be disappearing. The federal government's jumping on that bandwagon. And I think it's just going to become more and more the case down the road. So I think in order to be successful, you're going to have payer contracts, because that lucrative process of having out-of-network payments, I think, is going to disappear.
Yeah, I agree. I was thinking that as well. And more I'm seeing that even when you have to get into a dispute resolution, that seems to even be lower than if you were participating in a contract. So hopefully some of those panels and those networks are not going to close to ASCs. I would think, as you said, Amanda, that it's just so attractive to those, insurance companies and payers to have that lower cost that hopefully right now they're not closing those panels. I do see them being closed to physicians, their ER especially, that are trying to get on them, but I haven't heard anything yet about the ASC not being able to get on a panel. So question that just in closing and kind of wrapping this up, as we've talked about how to get a hold of you, I'm thinking that ASCs will continue to play a larger role in this delivery of healthcare and also office-based labs. And, again, for our listeners, if you're a provider listening into this, patient satisfaction scores is how you're getting your contracts renewed, and quality scores for, when you're dealing with certain payment models and everything. So my question is, and then this just in closing, and I'm going to get from both of you, get your take on this. Is it something that a single provider should consider, or if you're in a group practice, and should you consider doing this with, an institutional buyer, or is it really something that you recommend to clients that they really try to do this as part of their, practice extension versus going into a hospital? Or is that not even a question we can answer? It has to be based on the individual physician. I'll start with you, David.
My personal perspective is have an independent ASC or OBL. Don't go anywhere near a hospital. You start partnering with a hospital or a health system, the payer knows it's just going to run up the costs. Anytime you're dealing with one of those situations, cost is going to be influenced. I referenced this earlier. Here are the areas that anytime I open up a brand new practice or a facility, a surgery center, these are the things I want to glean from the client. And I mean really glean some information. One, what are you doing about improving patient satisfaction? Are you doing surveys? If not, start doing them. What are you doing about patient access? And patient access is all about communications, whether it's electronic, a portal, email, text, hours of operation, all of that type of stuff. Outcomes, quality metrics. You need to be participating in this because it's important to every payer. What are you doing to provide better outcomes? Do you have specifics about the procedures you're performing and what the results are? I mean, I've got a client that's got a very, very large OBL. They've got 15 locations. There are 12 different tax IDs. They're moving to expanding into other states. The payers are clamoring to get them in. And this is all because their whole mission is all about those 5 categories: patient satisfaction, patient access, cost efficiencies, outcomes, and quality of care. We nail those bullets down and we communicate exactly to the payer what we are doing to be a better partner for them and for the patients, and why they want us as a partner, as a surgery center, an OBL, whatever the case may be. And that almost always gets you in network as long as you've got valid points and you can really communicate that you are set apart from all the other competition in the area.
Nice. I agree with everything there. And I do that with payer contracts as well. I mean, just a little thing, with physicians. I said, if you're open on a Saturday morning or you have flex hours on a Thursday, you're setting yourself apart. Just little things like that. I agree. Now, Amanda, just in follow up for you, when you start this conversation with a provider or with an organization, do you talk to them about what is the first thing? Is it structure? Is it billing? Is it ownership? Is it the legal challenges? Or, what is it that you start the conversation with?
Well, first of all, I always ask, or at least try to gauge their what are their expectations? What do they want? At the end of the day, what do they want? And I'm hoping that they say, we want this to be an extension of our practice. We want this to be an investment opportunity. We want this to allow us further independence. It's a growth and recruitment strategy for our practice. And then it's also the ability, to piggyback on David again, to increase our patient satisfaction. Because again, patients drive the practice growth and practice revenue, all of those factors that the physicians hopefully want. They want to expand their practice. They want to extend the service offerings of their practice. They want to have a tool for future growth and recruitment and investment. And I think ASCs and OBLs are a great way to do that. And I think that's going to be the new wave of the future. Whereas we used to see a lot of different modalities being added, I think we're going to see a lot more investment in the ASC OBL world. So I start off with that question. And then from there, we look to see, is a partner needed? Because the partner has to fit the culture and the mindset and the expectations of the physicians and the practice. And there are many different partners out there, as I stated. They're all different. They all have pros and cons. And if a partner is needed, I will help the physicians maybe interview or find the right partner. But I do find a really high level of satisfaction, like David said, when a physician group does this on their own and they own it and they manage it and they develop it. And I know at the end of the day, it's a good feeling for them as well. So I think OBLs and ASCs are fantastic from a legal perspective, from an investment perspective, and frankly from a patient perspective as well.
No, that's awesome. And again, I agree. The future is bright for ASCs and office-based labs. Not just you and David, but many industry leaders stress that the importance of focused growth plans and other strategies to win the market. And again, payer contracts, management, and patient satisfaction. This is what's going to retain and attract surgeons and prosper in this market. So I'd like to thank Amanda and David for being on the podcast today. Your legal and business insights into this very timely topic was excellent. I hope our episode today has our listeners and providers thinking about the possibilities and the revenue streams that an ASC or an office-based lab can bring to your organization. So again, I want to thank you both for participating in this. This was great.
Thank you for having us.
Thank you, Terry.
You can reach Amanda and David again at NSCHBC.org. Go to the Find the Consultant tab and type in their first names, and their information will pop up for you. Again, thank you to Amanda and David for your expertise and insight today. As a reminder to our listeners, our second quarter Medicare update webinar is June 22nd, and you can register at NSCHBC.org and also check out our topics of discussion. That's it for us today, everyone. Please join us next month, July 12th, when my guest will be NSCHBC member Reed Tinsley, and we'll talk about how providers can regroup and recover after the pandemic, not only personally and professionally, but from burnout. Everyone, make it a great day, a great rest of your month, and thank you for listening to the NSCHBC Edge Podcast.
Thank you for listening to the NSCHBC Edge Podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.